Today we will speak about heavy menstrual bleeding. It's a very important topic, both clinical and academic. If you're going to go for your master's or your MRCG, you need to study hard the heavy menstrual bleeding and know the etiology, the investigation and the management, as well as for your clinical practice. It's a very common complaint which we receive from patients having heavy or irregular periods, and what shall we do? So we'll discuss that in this presentation. My name is Mohammed Nasharti. I'm a consultant obstetrics and gynecology in Kamtaf Morgano Health Board. So let's start with the etiology. And the etiology of dysfunctional uterine bleeding is classified into a phenomena by FIGO called palm coin. So P is a polyp. It can be either endometrial or endocervical polyp. It is usually benign. Minority may be malignant or atypical. And polyp can happen due to epithelial proliferation with a variable vascular, glandular, fibromuscular, and connective tissue components. It's often asymptomatic. Polyps are categorized as being either present or absent based on the ultrasound and or hysteroscopic imaging. And the B category can be subclassified based on the polyp dimension, location, number, morphology, and histology. If you go for adenomyosis, which is the A, relationship between adenomyosis and abnormal bleeding is unclear, and the prevalence of adenomyosis varies widely. It can be anything between 5 to 70%. The diagnosis is generally based on the histopathology evaluation of the depth of endometrial tissue beneath the endometrial myometrial interface in the hysterectomy specimen. However, ultrasound and MRI are increasingly used for diagnosis now. Given the limited availability of MRI, it's recommended that ultrasound criteria for adenomyosis comprise the minimal requirement for assigning an individual for diagnosis of adenomyosis. LEIOMYOMA, which is also described as myoma or fibroid, it's up to 70% in Caucasian people and 80% in African. It can be subendometrial, intramural, subserosa, or combination of all of these. It can be asymptomatic. Primary classification system reflect only the presence or absence of one or more leiomyoma, regardless the location, number, and size. Criteria for determining the presence of leiomyoma would require only ultrasound examination, confirming one or more. In the secondary classification system, the clinician is required to identify whether the leiomyoma is submucous leiomyoma from others, which is generally subserous or intramural, and we will go into that. And the tertiary classification includes the categorization of intramural and subserous, in addition to a category that include type, such as parasitic lesion, that become attached from the uterus after establishing the blood supply. Malignancy and include endometrial hyperplasia. Coagulopathy, which is a systemic disorder in homeostasis. Ovulatory dysfunction, and it generally manifests as a combination of unpredictable time of bleeding. It can be amenorrhea, oligomenorrhea, or unpredictable and heavy bleeding. Endometrial cause, and it is due to mainly deficiency in the local production of vasoconstrictor, such as indotherine 1 or prostaglandin F2 alpha, and or accelerated lysis of endometrial clot because of excess production of plasminogen activator. Don't forget the role of infection and inflammation. That's why chlamydia can be a cause of abnormal uterine bleeding. That's why intrauterine device can cause abnormal uterine bleeding. And then the iatrogenic cause, which is because of medication, which cause disturbance in the level of steroid. And the most common medication is the combined pills or progesterone-only pills, which can be missed by the woman, which cause irregular bleeding. However, sometimes the woman can take other drugs like antibiotics or anticonvulsant, which will affect the metabolism of the combined pills and accordingly will affect the level of steroid hormone in blood. Don't forget the drugs which affect serotonin uptake, as well as drugs which affect dopamine metabolism like tricyclic antidepressants. It all can cause irregular bleeding, and other causes which are not yet classified, such as chronic endometritis, AV malformation, myometrial hypertrophy, and assessment will start with history, then examination, then investigation. History, we need to identify the nature of bleeding, any associated symptoms like pain, discharge, manifestation of infection, post-coital bleeding, systemic causes of bleeding, impact on quality of life, patient fertility potential, because this will affect the treatment. You will treat the patient based on what she is looking for, and other factors that may affect treatment option like medical history, other comorbidities, previous treatment for heavy menstrual bleeding, need for contraception. If a woman has a history of heavy menstrual bleeding without other related symptoms, please consider pharmacological treatment without carrying out examination unless the treatment chosen is Mirena coil. So we know that the one has a history of heavy bleeding and there's no risk factor for malignancy or cancer in her history. In this case, you can start the treatment straight away. However, you will need to do the examination before all investigation or fitting a Mirena coil. So what investigation you are looking for with assessing the woman of heavy menstrual bleeding? First, you need to care about the general condition of the patient. So you need to find out, did this bleeding affect the patient or not? This can be done by asking for full blood count to see if the bleeding causes anemia and how severe is her anemia. Second, you need to investigate the systemic cause of heavy menstrual bleeding, which is coagulopathy. And you investigate it especially if the woman have some red flag symptoms or signs which can point out that the problem is coagulation, like having heavy menstrual bleeding since menarche, or having history of postpartum hemorrhage, or bleeding following any surgical operation or dental work, or personal or family history of bleeding, or any epistaxis, which is gum bleeding, which is lasting 1 to 2 times per month, or bruising 1 to 2 times per month, or frequent gum bleeding. Any two of these is enough to investigate for coagulopathy. Don't routinely carry out serum ferritin or hormone profile, and don't carry out thyroid function tests with women with heavy bleeding unless there are other signs or symptoms for thyroid disorder. But please don't ignore thyroid disorder as a cause of heavy menstrual bleeding. Then after looking at the general condition of the patient and investigating coagulopathy, if there is no risk factor for cancer or her history doesn't point out to an endometrial or uterine pathology, in this case you can start pharmacological treatment straight away. However, if the history point out to an endometrial or uterine abnormality or the risk of cancer, then you have to investigate the endometrium. And investigating the endometrium can be done by one of two ways. It's either ultrasound or outpatient hysteroscopy and endometrial biopsy. Ultrasound has a high sensitivity. It can identify presence of uterine polyp. It can identify the endometrial thickness. It can identify presence of fibroid. It can locate the size and size of fibroid. It has specific features to identify adenomyosis. However, if the woman history is significant for malignancy, she needs a papilla biopsy. And if we're going for having an endometrial biopsy, we prefer do it under vision, which is outpatient hysteroscopy and a biopsy. And usually the outpatient hysteroscopy can be done with oral analgesia before the procedure and the use of vaginoscopy as a standard technique. However, if the outpatient hysteroscopy is not suitable or the patient decline, then she can have the hysteroscopy under general anesthetic. Please, endometrial biopsy is a must in these situations. In case of persistent intermenstrual or irregular bleeding, in case of infrequent heavy bleeding in women who are obese or having polycystic ovary syndrome, women taking tamoxifen, women for whom treatment of heavy menstrual bleeding was unsuccessful, and in general in women over 40 to 45 with heavy menstrual bleeding, you need endometrial biopsy. And in case you need a biopsy, it's preferable to do it under vision, which is hysteroscopy and endometrial biopsy, so we don't offer blind biopsy to women with heavy bleeding. However, if the history and examination are suggestive for a pelvic abdominal mass, which I mean large fibroid, in this case you need to have pelvic ultrasound, because pelvic ultrasound will be able to locate the size of the uterus, where is the fibroid, what's the number of fibroids, what is the size, and even if it is difficult, we need more confirmation, you can go for an MRI. LEIOMYOMA subclassification system. So first you need to know, is it some mucus or other? And some mucus, it's 0, which is pedunculated, 1, less than 50% intramural, 2, more than 50% intramural. Other is 3, which is contact the endometrium, so it's 100% intramural, 4, intramural, 5, subserosal with more than 50% intramural, 6 is subserosal with less than 50% intramural, 7, subserosal pedunculated, 8 is other, and you have to specify is it cervical or parasitic. If the history and the examination is suggestive of adenomyosis, as the patient is having significant dysmenorrhea, or on examination the bulky tender uterus, in this case transvaginal ultrasound is the preferred method of investigation. And if the one declined transvaginal ultrasound or not suitable, in this case you can consider transabdominal ultrasound or MRI. However, don't use saline infusion sonography or MRI as a first line for diagnosis of heavy menstrual bleeding. Don't use dilatation and the curette alone as diagnostic tool for heavy menstrual bleeding. So what's the treatment for heavy menstrual bleeding? First line is levonorgestrel intrauterine system, which is the Mirena. We consider it in case of no identified pathology, or a fibroid which is less than 3 cm in diameter and not causing any distortion of the uterine cavity, and I have to emphasize that there is no distortion in the uterine cavity, or in case of suspected or diagnosed adenomyosis. However, if the Mirena coil is declined or not suitable, in this case you can consider first line, which is non-hormonal, like tranexamic acid and non-steroidal anti-inflammatory drugs. Usually we give tranexamic acid as 1 gram TDS in the first 3 days of the cycle. It helps to reduce the bleeding a lot. If combined with mefenamic acid, which is non-steroidal anti-inflammatory medication, it helps to reduce the pain associated with the cycles as well. Second line will be hormonal, which is be either combined pills or cyclic progesterone, but please refer to the UK medical eligibility criteria before prescribing the combined pills or progesterone, so make sure that the patient has no contraindication for these medications. Alternative is a surgical option, which is endometrial ablation, and the last will be hysterectomy. And in women who have some mucus fibroid, we have to consider hysteroscopic removal of the fibroid. So what to do if the woman has a fibroid of 3 cm or more in diameter? In this case, Mirena coil is not suitable. So again, we will start with non-hormonal treatment, as we said before. And we have hormonal treatment, which is the combined pills and the progesterone only pills, but we can use ULIPRISTAL acetate as well. Tranexamic acid can be given at a dose of 2 to 4.5 gram per day, and the most likely dose which we use is 1 gram TDS for 3 days at the start of the period. It does not reduce dysmenorrhea, that's why we add it with non-steroidal anti-inflammatory drug, which is mefenamic acid. It is not contraceptive indefinitely and has no role in regulation of the cycles. Tranexamic acid can be given either oral or intravenous in case of severe bleeding. Side effects include a change in color vision, blood clots, and allergic reaction. It's antifibrinolytic agent. Reversibly bind to plasminogen and reduce the conversion to plasmine. Accordingly, it prevents fibrin degradation and preserves the framework of fibrin matrix structure. Has roughly 8 times antifibrinolytic effect of an older analog aminocaproic acid. Non-steroidal anti-inflammatory drugs, which mainly mefenamic acid or naproxen. It can reduce the menstrual blood loss by 20 to 49%. Also, it is not as effective as danazole or tranexamic acid, but has a better adverse effect profile than danazole, and is very good as a pain relief as well. So that's why it's cost effective if compared to no treatment. It is not contraceptive as well. It's beneficial for treatment of dysmenorrhea. Shouldn't be used if the heavy menstrual bleeding is caused by bleeding disorder. That's why it's very important to investigate that the cause of heavy menstrual bleeding is not due to coagulopathy. Due to the cyclic nature of its use, adverse effects are reduced. No evidence regarding the effect of non-steroidal anti-inflammatory on heavy bleeding in the presence of uterine fibroid, as women with fibroid were excluded from the trials. And it makes sense because the fibroid is an organic pathology, and accordingly it needs to be treated separately. But non-steroidal anti-inflammatory drug is mainly for dysfunctional uterine bleeding with no valid reason. Please be aware that ULIPRISTAL acetate can cause serious liver injury, also it's rare. That's why you have to monitor liver function for the first 2 treatment courses. and as clinically indicated. When used for intermittent treatment in women who are not eligible for surgery or where the woman declined surgery, you can offer it 5 mg up to 4 courses. ULIPRISTAL is indicated for one course lasting up to 3 months in case of pre-operative treatment for moderate or severe symptoms of uterine fibroid, and for intermittent treatment up to 4 courses of moderate to severe symptom of uterine fibroid in adult women who are not eligible for surgery. However, there is a very high risk of serious liver injury, and so if we go for surgery, first you have to ask yourself, what is the woman's potentials for fertility? Does the woman want to preserve the uterus or not, especially in case of fibroids? So if the woman wants to preserve the uterus and she would like to go for future fertility, then you have two options, either embolization or myomectomy. And in this case, you need to make sure about the location and the size of the fibroid. However, if the woman doesn't have any potential for fertility, then we can go for endometrial ablation. And then if unsuccessful or the woman decline, we can go for hysterectomy. Remember, we can use gonadotropin releasing hormone analog or ULIPRISTAL acetate in order to reduce the size of the fibroid and reduce the amount of bleeding at the time of surgery. For uterine artery embolization, they are very efficient for symptom relief in short and medium term with no major safety concern. Symptom relief may not be achieved, but symptoms may return, and further procedure may therefore be required. Effect of the procedure on fertility and on pregnancy is uncertain, undertaken under conscious sedation and local anesthesia. Its efficacy is 84 to 83% of patients had improvement in their symptoms after embolization at 6 and 24 months respectively. Mean uterine volume reduction 40%, and mean reduction in fibroid is about 2.2 cm. Reintervention rate is 15%. Safety, uterine infection can occur up to 2%. Septicemia and emergency myomectomy or hysterectomy up to 3%. Arterial dissection or perforation, groin bleeding or pseudoaneurysm, femoral artery occlusion, bowel perforation, uterine infarction, bladder and vulvar damage, ovarian damage, post-embolization syndrome, pain, premature menopause, and vaginal discharge are all known side effects but very rare. For uterine leiomyosarcoma, most of cases are discovered by incidental pathology finding in women undergoing hysterectomy or myomectomy. For a myometrial mass, the prevalence of sarcoma is about 0.2, so 1 in 500. Average age is 51. It's often discovered by chance when a woman has a hysterectomy performed for a fibroid, and that's why the use of morcellation was prohibited by the FDA till they invent the closed back morcellation because of this instance of leiomyosarcoma. Surgery is the primary therapy for patients when they are first diagnosed. The tumor hasn't spread beyond the body of the uterus, stage 1 or 2, in approximately 70-75% of patients. The tumor tends to be aggressive actually. 5-year survival rate is only 50% with patients whose the tumor is confined within the uterus. Women with the uterine leiomyosarcoma that has spread beyond the uterus and the cervix has a very poor prognosis. Thank you.